Hello everyone. Today we will be discussing our research, which was on the correlation of ankle range of motion with dynamic balance in college-age individuals while performing a modified Y balance test. I'm Alexis.
I'm Brooke.
I'm Casey.
Here's a little background on our study. The Y balance test is an objective and reliable measurement of dynamic balance. It measures the reach distance in 3 different directions. You have the anterior direction, the posterior right direction, and the posterior left direction. If you're familiar with the standard Y balance test protocol, you may be hearing these terms a little different as they generally go by posterior medial and posterior lateral. However, we chose the right and left directions for consistency purposes during our data processing. The Y balance test is derived from the star excursion balance test and includes participants standing on a single leg stance while reaching with their opposite lower extremity in each of the 3 directions. Up on the screen, you will see a picture of the standard Y balance test, which is actually the same make and model that we used to perform our study with. As you can see, there are 3 bars going in each of the 3 directions, and each bar has a foot plate over them. So just to kind of get you oriented, the inferior most part of the screen is the anterior direction, and the left and right corners are the posterior directions. The individuals would stand facing us on the middle plate with their toes lined up on that little line you see in the center of the screen. The distance recorded is the maximum distance that the individual is able to move this foot plate in each of the 3 directions. It should also be noted that participants must return to their starting point after displacing the foot plates without losing their balance or touching the ground, or the trial will have to be reperformed. The purpose of this study was to determine if increased active ankle range of motion was correlated with improved balance in college-age individuals. A secondary focus of the study was to determine if demographics such as age or BMI would be correlated with ankle active range of motion or modified Y balance reach distances. Our hypothesis was that increased active ankle range of motion would be correlated with increases in reach distances on the modified Y balance test, thus resulting in superior dynamic balance.
Our subjects were Clark University students between the ages of 18 and 24 years old. Subjects were excluded from our study if they had sustained a lower extremity injury within the past 3 months. The average age of our participants was 22.65 years old, and average BMI was 24.36 kilograms per meter squared. We recruited our participants via convenient sampling and had a total of 13 males and 13 females, combining for 26 total participants. Our study followed a correlational design with researchers blinded to intake questionnaire information as well as to range of motion assessments prior to Y balance testing. We used a standard goniometer and a standard Y balance test to carry out this research. Our independent variable was active ankle range of motion in the directions of dorsiflexion, plantar flexion, inversion, and eversion. Our dependent variable was reach distances on a modified Y balance test. Upon arrival to testing, participants filled out an informed consent as well as a questionnaire, which inquired about participant age, height, weight, and any history of lower extremity injuries. Participants were assessed for range of motion on an elevated surface so that they were in a non-weight-bearing position for these measurements to be taken. We also had the same researcher complete all of these assessments to improve reliability and consistency. Next, participants were sent to a separate part of the room to complete the modified Y balance test. Participants began on their right lower extremity and were allowed 1 practice trial in each of the 3 directions, anterior, posterior right, and posterior left. They were then assessed for 3 assessment trials and before switching to their left lower extremity. They were again allowed 1 practice trial followed by 3 subsequent assessment trials. Participants were given a 30-second break between trials, and the average was calculated of the 3 trials in each direction.
All statistical analyses were performed using IBM SPSS Statistics 24 USA. With this study, we completed a correlational analysis with a linear regression to determine the relationship between ankle active range of motion and Y balance test scores. We chose to conduct a Pearson product moment correlation coefficient to determine the strength and direction of association that exists between these two variables measured on an interval scale. An interclass correlation coefficient value was obtained for each of the three directions bilaterally and was found to be greater than 0.90, implying excellent reliability of the modified Y-balance test measurements. Here, we also found correlations that relate to our research question. A positive relationship was seen between right ankle inversion active range of motion and right posterior right reach distance. So this is when a participant was standing on their right lower extremity and reaching towards the right direction with their left lower extremity. An inverse relationship was also seen between right ankle dorsiflexion active range of motion and the right anterior reach distance. After performing ankle active range of motion measurements, we calculated the averages for males, females, and the total. In the first column here, it's the normal active range of motion values, followed by the total males and females. Of the 26 participants who participated in our study, both males and females displayed an average of 10.03 degrees of dorsiflexion, 61.20 degrees of plantar flexion, 36.80 degrees of inversion, and 27.45 degrees of eversion. Participants also completed the Y-balance test with averages in the anterior reach direction of 1.93 meters, the posterior right reach direction of 2.72 meters, and the posterior left reach direction of 2.73 meters. Even though the males did achieve higher modified Y-balance test scores than their female counterparts, there was no significant difference found between the two, with a p-value of greater than 0.05.
I'd now like to bring your attention to the summary table of our main results of this research. At the top, you will notice there are two variables, which represent significance between the two variables if you go across in the horizontal row. This is followed by the correlational value, as calculated by the Pearson product correlation coefficient and represented as an R value. In the right-hand column, we have the p-value, which is listed in order of greatest statistical significance at the top, followed by least significance at the very bottom. The first three rows simply represent that the directions on the bilateral lower extremity and the posterior right and left directions were all correlated with each other as we would expect. This had a p-value of less than 0.001. Next, we see that right dorsiflexion active range of motion had a negative correlation with BMI with a p-value of 0.006, meaning that individuals in our study who generally had higher BMIs demonstrated less dorsiflexion on the right lower extremity than the counterparts who had a lower BMI. Next, we see 2 points with arrows and highlighted that relate to a research question that Brooke already mentioned. So right inversion had a positive correlation with the distance in the right posterior right reach distance with a p-value of 0.008. Next, we see that age and left eversion had a negative correlation with a p-value of 0.023, demonstrating that individuals who were older in our study generally had less available eversion active range of motion. Next, we see a right dorsiflexion active range of motion interestingly had a negative correlation with average right anterior reach, which was an unexpected finding in our study with a p-value of 0.041. Lastly, we see right eversion and right dorsiflexion active range of motion were both significantly correlated with each other with a p-value of 0.041 as well. Here's a scatter plot we created between the most important findings in our research. We see right ankle inversion at the bottom of the graph and right posterior right reach on the y-axis of this table. So as you can see by the bolded line, it represents the best fit line of all the data points. As individuals demonstrated more inversion, they were generally able to reach further in this said direction.
We found that our data supported our hypothesis to a limited degree, specifically for ankle inversion, active range of motion, and posterior reach on the modified Y-balance test. We were able to draw several conclusions related to physical therapy. First, because of the strong positive correlation we found between ankle inversion, active range of motion, and posterior right reach distances on the modified Y-balance test, ankle inversion range of motion may be important for athletes who require lower extremity control while in hip extension. During a baseball pitch in the late cocking phase and into the acceleration phase, we see a very similar position and movement pattern as is demonstrated on a posterior reach of a Y balance test. Next, we found higher level BMIs may be correlated with decreased ankle dorsiflexion range of motion. Other research has shown that decreases in ankle dorsiflexion are correlated with decreases in balance assessment scores, indicating an increased fall risk and increased injury risk. Lastly, we found strong positive correlations between posterior reaches between lower extremities in both the right and left direction on the modified Y balance test, which was expected since our participants were all without lower extremity injury. However, when assessing an athlete's ability to safely return to play after suffering a lower extremity injury, research has shown that there should not be greater than 4 centimeter differences in each of the 3 directions between lower extremities. If it's greater than 4 centimeters, this indicates a significantly higher injury risk. Therefore, we believe that athletes should be cleared with some form of a Y balance test prior to returning to their sport after suffering a lower extremity injury to decrease future injury risk.
One limitation that can be noted from the study was that our participants only completed 1 practice trial instead of the 6 practice trials outlined in the standard Y balance test protocol. This may have not been a sufficient amount in order to achieve optimal neuroplastic adaptations and plateau on reach distances prior to the assessment trials. However, more recent research studies have shown that 4 practice trials may be sufficient. Another limitation was that we had our participants to perform the 1 practice trial and 3 subsequent trials in each direction on the right lower extremity, followed by all repetitions on the left lower extremity. Active range of motion assessment could have also been assessed in weight bearing, as this would have been more specific to the Y balance test. Leg length measurements were also not recorded in the study, limiting the ability to distinguish greater modified Y balance test scores being from either improved balance or from increased leg length. In our study, the participants were told to place their feet on top of the foot plates rather than only touching the red target area of the foot plates that was suggested for the standard Y balance test assessment. This could have assisted participants with steadying supports throughout the reach, thus possibly increasing the distances reached on the modified Y balance test. Lastly, the total number of participants only consisted of 26 individuals, a relatively small sample size that may have hindered the reliability of the results, decreasing the ability to be generalized to all college-age individuals.
Here's some future research that may stem from our study. First off, including participants with a previous history of ankle injury may be useful for practitioners who are treating a patient, say, after an ankle sprain or an ankle fracture, as this was one inclusion or exclusion criteria in our study. Next, possibly gathering data on leg dominance may be important for determining if an individual is more comfortable on one limb versus the other, and therefore may affect the distance that is reached on the Y balance test assessment. Next, performing this study on a more diverse population may be beneficial, as there's a lot of research on the geriatric population, but not a lot on other populations, especially the pediatric population, and this may give us useful information for treating patients in the future. Next, using different balance assessments, such as ones that are more inclusive of only static balance, may be useful, as the Y balance test we use is really only inclusive of dynamic balance. Lastly, performing a strength assessment, such as a manual muscle testing prior to performing the Y balance test, may give us a more clear idea on the role of neuromuscular control while performing a single leg stance. Here are our references. And next, we would like to thank our professors, the Clark University faculty, all our family and friends, and most importantly, the participants of our study who really helped us with the requirements needed to be successful with this research. Thank you.